And thank you very much, everybody, for joining us this evening for this Greater Manchester GP CPCS Pharmacy Engagement webinar. I'm joined this evening by my colleagues Louise Gatley from Bolton LPC and Lovejit Kandula from GM LPC. My name is Alison Scowcroft and I work for CHL, the pharmacy provider company. So I'm just going to do a little bit of an intro for you, and then I'll hand over to Louise and Lovejit, who are going to go through the detail of the webinar for you this evening. Could we have the next slide, please? So just a little bit of an overview of the Greater Manchester Healthcare Academy. Hopefully you guys are aware of this and have heard of us. It's a training platform for community pharmacy in Greater Manchester. So we do run lots of events and we support the whole pharmacy team. Next slide, please. The Academy is founded by the partnership along with the GMLPN, both LPCs and CHL, and supported by CPPE. Next slide, please. And just a quick note about service delivery in Greater Manchester. The future of community pharmacy depends on us all. It's really important that commissioners and the whole healthcare system see our potential for delivery. So the Academy is very much supportive of community pharmacy, but we need you to step up and embrace new service opportunities, particularly GP CPCS, because this is such high profile with the involvement of general practice as well as community pharmacy within GM. So please do embrace this opportunity and use it to maximise and really enhance those relationships you have with general practice. We're also going to do a poll throughout the evening, and this is really important because we're really keen to get your feedback on this session. The Academy and both LPCs and CHL really value feedback from contractors and attendees at events such as this, and we do work really hard to address any feedback, constructive or positive, that's shared with us, and make sure we're continually improving. So please do complete the poll. We'd really appreciate if you do that before you leave us this evening. We do have an hour, so we're hopefully going to keep to that time and get you away before 8 o'clock, so you can get on with your evenings. And I do just have, before we get started into the agenda for this evening, a really good announcement to make. We're really pleased about this. We've been able to secure access to virtual outcomes for all pharmacy contractors for the CPCS content that's in the virtual outcomes platform. I'm not sure if contractors are aware of virtual outcomes. It's a really good e-learning platform that's specifically pharmacy focused. And the way that it's structured is it's quite useful bite-sized videos that you can watch with some questions afterwards, and then you can print a certificate to demonstrate that you've completed that e-learning. There's also some modules in there for general practice teams, which we're going to use as part of the general practice staff training. So really pleased to announce that we've managed to secure access to all GM contractors to that virtual outcomes platform for CPCS, and your LPC will confirm in due course how you can access that service. Next slide, please. So just a quick overview of the agenda. I'm going to hand over to Lou shortly, and she's going to give you a bit of an overview of GP CPCS service and how it differs from the current NHS 111 service. And she'll also give you a bit of an overview of some of the processes that we've agreed locally in GM. Lou will then hand over to Lovejit, who will talk to you about what we're doing in GM in terms of rollout and implementation, a little bit about local engagement, and some tips and information for you there. And then we'll have enough time at the end, hopefully, for some questions, which we will all be involved with. Do put your questions in the Q&A as we're going along. As I said, we will endeavour to answer those as we go. Next slide, please. So just a quick run through of what hopefully you're going to get out of this evening. By 8 o'clock, you should be able to understand how the GP referral pathway fits into the overall CPCS service, and understand what that referral pathway is and how it works. You should understand what the GM protocols and escalation process are. So they're the locally agreed processes that I just mentioned earlier that Louise will go through. And you'll also understand how the local engagement of the service in your area with key stakeholders will take place. So I'm going to hand over now to Louise, who will take you through an overview of the GP CPCS service. Thanks very much, Lou.
Thanks, Alison, and good evening, everyone. Thank you for joining us. I'm Louise Gatley. I'm the Chief Officer of Bolton LPC. I want to spend the next few minutes going through an overview of GP CPCS, the key differences from the NHS 111 pathway, and some of the agreed local processes for Greater Manchester. And the next slide, please. Thank you. So I'll start with the background to the service. The NHS CPCS is a nationally commissioned and funded advanced service that was launched in community pharmacy across England in October 2019. As part of this service, electronic referrals from 111 are made to community pharmacies for patients with minor illness or those needing an urgent medicine supply. A pathway to expand this to general practice for patients with minor illness only was successfully piloted across the country, including parts of GM. And the decision to expand this service to include referrals from general practice to all of community pharmacy was agreed from November last year. As we go through the presentation, it's important to note really that over 90% of referrals in the pilots were fully completed by community pharmacy without the need for any escalation or referral back to the GP, which means on the whole, the GP teams have been trained and supported to identify the most suitable patients for us. Can the next slide, please? Okay, so looking at what's new, like I said before, this is an extension to the existing CPCS service for patients with low acuity conditions. So there's no need for you to sign up for the GP pathway if you're already providing CPCS via 111. What it aims to do is to formalise the current care navigation pathways in general practice, and also to provide some data to support the value of community pharmacist-led interventions. As part of the service, there's an agreed escalation pathway back to the GP, which I'll go through shortly, and a post-event message sent back to the GP as well. And that's really to ensure the practice knows what has happened to their patient and to help build confidence in the service and the practice end. The payment is the same for both pathways at £14 per consultation. And can the next slide, please? Thank you. So the aims of the GP pathway is to improve access to primary care by referring patients requiring advice and treatment for minor illness from the GP practice to a community pharmacist. The service is expected to relieve pressure on general practice and create capacity by referring patients who would otherwise have attended a GP appointment. So this really is about patients being seen by the right healthcare professional at the right time and in the right place. And it's about community pharmacy being integrated into local NHS pathways and demonstrating its place within the NHS to manage patients with minor illness. It's also hoped that it'll go some way to re-educating patients to go to the most appropriate health professional for their needs in the future first, and also to build and enhance relationships between primary care providers. On the next slide, please. So this here is just a useful infographic we thought we'd show you from PSNC, and it just highlights some of the key stats. And the important bits to note here are that around 94% of pharmacies are already signed up to deliver the service. So we've got great coverage across our network. It's also estimated that around 6% of GP appointments can be referred on to us. So that's around 1 million appointments per year in Greater Manchester, or 30 appointments per week for the average pharmacy if we reach that 6% referral level across all of our practices. The number of referrals a pharmacy gets is going to very much depend on each practice, so building local relationships between yourselves and local practice teams is incredibly important. They need to have confidence that you'll pick up the referrals promptly and that you'll manage their patients. And next slide, please. So let's have a look at some of the pathways, the national pathways in a bit more detail. And these can be found in the toolkit, and we've linked that for you at the end of the presentation. So this slide shows the pathway from both NHS 111 and GP practice. Entry into the service will start with the patient contacting one of them, so either the 111 service or their practice. And if it's appropriate, they'll be referred to a community pharmacy of their choice, with the end point being that a referral arrives at the pharmacy electronically. So currently NHS 111 referrals arrive into Farm Outcomes, and for GP referrals, the service will launch with the GPs having an electronic solution directly into Farm Outcomes as well. So they'll arrive in the same way as the referrals from 111. Next slide, please. So for today, we're going to focus on the GP pathway. And this here is quite a complex slide, but it does show the whole pathway from the point that the patient has been referred by the practice until they exit the service. And I'll break this down a little bit later on in the presentation. So following the referral, patients will be told that the pharmacy will contact them directly and to wait for a call within 2 to 3 hours. And this is a little bit different from the 111 referral. They won't be encouraged to immediately phone you or to just turn up. The reason that this route has been agreed is it allows you to manage the workload in the pharmacy and not to potentially have to deal with a number of referrals first thing in the morning, as that's the time that patients are most likely going to be contacting their GP for appointments and referrals being made. So what it'll do is allow you to spread the consultations out across the day at a time which most suits you and the way your pharmacy works. But as we all know, patients will often do their own thing. And despite being told to wait for a call, some will immediately try to contact you by phone or just walk in. So direct contact from the patient is also included in the pathway, as we recognise that this is going to be an entry point for some patients. The next stage is the clinical consultation with the patient, which will include making the appropriate electronic health record and accessing SCR or NICE CKS as appropriate. The service has then got a number of different exit points, which I'll cover in the next slide, but the end point for patients who are not being escalated is you providing any relevant information and support to patients, advising them that if their symptoms don't improve or become worse, to come back and see you or to seek advice from their GP. And I suppose the really important point to remember with this is not all patients are going to be your regular nominated patients, and there should be no attempt to change the patient's use of their usual pharmacy as a part of this service. And the next slide, please. Thank you. Right, so if we move on to consultation outcomes, I'll cover this slide really quickly because in effect it's the same as the 111 referrals, which most of you are going to be familiar with. There's 6 exit points, which are advice only, advice and an OTC sale, advice and referral to a local minor ailment service if one is commissioned in your area, advice and urgent signposting, non-urgent signposting, urgent escalation to the GP, and finally urgent referral to urgent care. And at the end of the infographic there, we've got the 3 boxes, and that covers the GM specific escalation process, and we'll cover those in a bit more detail later. And the next slide, please. Okay. So service availability and the practicality of delivering the service are key to GP CPCS being a success. Some really important points you need to consider to ensure you meet the service specification and deliver the best possible service to your patients. GP CPCS needs to be a service your local practices will be happy to refer to, one your pharmacist and your locums are going to deliver. So firstly, the service must be available throughout your full opening hours. So that includes your core and supplementary hours on every day that you're open. So it's really important to keep your NHS UK, your DOS profiles up to date so patients and practices are aware of your opening times. You should check pharm outcomes for referrals regularly throughout the day, and as a minimum check the NHS share mailbox first thing in the morning and last thing in the evening, as that's going to ensure that you pick up any referrals that might have defaulted to NHS mail as a result of a pharm outcomes outage. And that's something that many of us have seen over the last few months with CPCS from 111. You must also ensure that you have enough staff who are able to access the shared mailbox throughout your opening hours and put in checks so that you can be sure that it actually happens. That's especially important at weekends and evenings when regular managers and staff might not be in. Sorry. So these IT checks are some of the most important parts of the service. There needs to be a robust process in place in your pharmacy to ensure every referral is picked up no matter which members of staff are working. It's only going to take one misreferral for a GP and potentially a whole PCN to lose confidence in the service and stop referrals. And we know from experience in other areas that once referrals are stopped by a practice, it's incredibly hard to get them started again and to build that confidence back. So all team members, including locums, relief pharmacists, need to be aware of the procedures to follow and also the processes that are needed in case you do need to temporarily suspend the service. Key contact numbers and other contact details should be accessible to all and recorded in your SOP. If you do need these details, please contact your LPC and we'll be happy to provide them for you. Or you can find them on the Services tab on Pharm Outcomes under Annex C, and there's a downloadable PDF with all the details for GM on there. Finally, when locums are being booked to work at the pharmacy, please ensure they are made aware that CPCS is being provided and ensure they can provide the service and have all the information they need and access to any IT systems. And next slide, please. Okay, so I'll move now on to the draft processes, not the drafts, sorry, the actual agreed processes now for GM. These escalation routes and protocols I'm going to show you have been agreed at a GM system level and they'll be used in the service going forward. Next slide, please. So this slide here shows one of the referral protocols that was used with some of the pilot sites, and this is going to be provided to all practices who are planning to go live. As you can see, the conditions included have been chosen to be low acuity conditions with some safety netting around some of the common red flag symptoms, which will reduce the risk of any appropriate patients being referred. It'll be used by GP reception teams and care navigators, and they'll have received some training and support around this protocol and how to make the referrals. They'll have also received some additional training regarding the EMIS referral process if they use the EMIS system, or Farm Refer for the other GP practice systems as well. And the next slide, please. So this slide here shows the GM referral process, and it builds on the national process that I showed you earlier. It always begins at the GP practice. The service spec doesn't allow patients to self-refer. So the patient will initially contact the GP via telephone or sometimes an online triage system. The care navigator or the receptionist will assess the patient against the agreed list of conditions which are suitable for referral, and if it's appropriate, they'll make an electronic referral to a community pharmacy of the patient's choice. The referral details will be sent through to the pharmacy as an electronic message into Farm Outcomes, and the pharmacy will then contact the patient, and the pharmacist will carry out a consultation either remotely or face-to-face. They'll make the appropriate health records in Farm Outcomes and access summary care records and NICE CPCS as appropriate. The key parts to note are the patient will be told by the practice staff that they'll be contacted by the pharmacy within 2 to 3 hours, or the next day if it's later in the afternoon. They'll also be advised that if the pharmacy doesn't get in touch for some reason within that 3-hour window, that they should contact the pharmacy themselves. You'll notice on the slide that we've added a 2:30 p.m. cutoff for patients to be contacted the same day. So for those referrals that do arrive later on in the day, and sometimes this might be quite close to the time that you're going to be closing, it's up to the pharmacist to make a professional judgment to assess if the patient requires urgent contact that day or if it can wait until the next working day. That's especially important if your pharmacy is going to be closed the next day. It is a professional decision from the pharmacist to decide if it's appropriate for a patient to wait, potentially over a weekend, for more than 48 hours. And the next slide, please. So earlier I mentioned that some patients won't wait for a phone call from the pharmacy. So it's important that the pharmacy team can correctly identify them. Ideally, patients who don't wait for a call from us will inform you that they've been referred by the GP. But as we know, this message from patients might not always be very clear. They might not understand the process themselves either. So patients are going to say a variety of things, and we've got some examples there of things that patients might say and have been said in the pilots. Some patients may not even tell you they've been referred at all, and they may just present as a patient requesting general self-care advice. So you need to ensure your team are aware that patients may present in different ways, in person or by phone, and that they may not remember to tell you that they've been referred. It might be wise to put up a poster or something on the pharmacy counter just to remind patients to let you know if they've been referred, and that could be via the GP or 111. If a patient's unclear, ask them some more questions about what they've done prior to contacting the pharmacy that day. Double check Farm Outcomes in the shared mailbox just in case the referral's dropped in there between the checks that you're making. And remember, finally, that if you process a CPCS as an OTC sale, all self-care advice, and you later realise that it should have been a CPCS, that you're not able to claim the payment. And the next slide, please. So moving on now to my last couple of slides and the escalation processes. These define how to safely transfer a patient back to the GP or onto urgent care for conditions that cannot be managed by the pharmacy. So there's 2 escalation processes to consider. There's one for urgent escalation and one for non-urgent escalation. I'll start with this one here, which is a non-urgent escalation pathway. And this is patients who require a routine appointment with the practice. Don't set any expectations for patients. Don't tell them that the GP will do specific things. That's for the GP to decide. It may be worth you having conversations as you know practices are going live, just to discuss the processes with them and build that relationship and understanding of how the service is going to work between you and your local teams. And that might also be an opportunity for you to ask for a direct number that you can use for referrals if the practice has got one, rather than waiting in the usual queues that think we're all quite used to right now. So for the non-urgent escalation pathway, the pharmacist should contact the practice and explain the patient requires a routine appointment following a GP CPCS referral. The practice may allow you to make the appointment for the patient there and then, or they may want to contact the patient directly themselves, and either way is absolutely fine. We just need to ensure that the GP has a report of the consultation available for them for the appointment, and that will generally be sent via the Pharm Outcomes system as you complete that template, but it can also be printed off and given to the patient or sent via NHS mail as well. And next slide, please. And then moving on to the urgent escalation pathway. This one's for patients who need to be seen urgently that day, either in hours or out of hours. Again, don't set any expectations of specific treatment or outcomes. That's for the clinician you're referring to decide. So we'll start with the in-hours escalation. Again, it's the pharmacist, and you should contact the practice and explain that a patient requires an urgent same-day appointment following a GP CPCS referral and arrange that appointment for them with the practice. Patients should never be advised to contact the GP and make the appointment themselves, and that's a really important thing to remember. Again, you'll need to ensure the GP has got a report of that consultation available to them. And then for the out-of-hours appointments, there are two options: either to send the patients directly to A&E or to call 999 if it is really incredibly urgent, that's what's needed, or to call the NHS 111 healthcare professionals line. And you can find the details of that in the Annex C, which I've just referred to earlier, and that can be found on Pharm Outcomes. And they'll provide advice, and that might result in an onward referral to a suitable service, for example, the out of hours. So whichever pathway is taken, the service ends with the routine message back to the GP so they know what has happened to their patient. And that's the end of my part of the presentation, and I'll pass it over to Lubjit to continue.
Good evening, everybody. Thank you so much, Lou, for that very comprehensive overview, and thanks to Alison as well for starting. So I'm just going to be talking this evening about the GM rollout plans for GP CPCS. So next slide, please. Okay, so fundamentally what we're doing in GM is we've set up something called the GP CPCS working group that basically consists of GM LPC members, Bolton LPC and CHL. So we're all working together as a team to try and support the rollout of GP CPCS across Greater Manchester. Once we've undertaken the local engagement, then it will move to a phase of go live support. So the team here, particularly led by Alison as a project manager, will be supporting general practice to go live and train them on the protocols, train them on how to use the system, and also do some test referrals to ensure that it works. And then finally, in the latter phase, after we've tried and tested it with early adopter areas, we will plan a phased rollout for the rest of GM. And as time goes on, we will be developing resources and support to help you along that journey. Next slide, please. So in terms of GM system engagement, just so that we've got an overview and a bit of an appreciation of what kind of level of engagement we've had to do, I think I counted it was at least 34 meetings of engagement at senior system level to get to this point. So there's the Greater Manchester Health and Social Care Partnership Project Oversight Group. We've then gone to engage with the Primary Care Board members. We have then taken it through the governance of the Primary Care Cell, the Primary Care Digital Board, and also the GP Provider Board and LMC. The next phase of our engagement will be to follow up with CCGs and meds optimization leads. Some of that engagement has already started, and to remember that we are doing this in partnership with the Primary Care Board and in partnership with the GM Health and Social Care Partnership as well. So we want it to be a collaborative piece of work, so everybody's been brought into the journey and really understand that it's the right thing to do. It's a critical opportunity at the moment because we know that the system is very stressed. We know that general practice need to move back into routine practice. So anything that we can do to ease the pressure off them is really welcome at this time. So in some ways you could argue that that joint working that we've done over the pandemic has really helped to open that relationship. So I do encourage you to continue to build great relationships with your own general practices while we are working on that engagement piece. And then community pharmacy contractors, obviously that's through this webinar and providing you with support, and then we'll engage with you further on the go live phase, and then engagement with the primary care networks, which I've explained we've already started, and then engagement with individual general practices to train frontline staff to start referring to community pharmacy. Next slide, please. Thank you. And then just moving on to local engagement. Next slide. Yeah, so just to reiterate then, so LPC-CHL are liaising with the GM system to engage with the service. That includes CCGs and primary care networks. We have already developed some information for you, a briefing and a presentation deck that has been provided to all contractors and PCN leads, which contain key messages for you to help you have any local conversations. I just want to make an important note here for you that contractors and PCN leads are not being asked to proactively engage. However, we do understand that some of you are being approached by your general practice or your clinical directors or PCNs because of the great engagement you've done. But we have provided that tool for you so that it can make it, you know, you're supported, and you can always get in touch. If any contractors have already received referrals via NHS Mail, and particularly if you are not part of the GM pilot, please let your local LPC know so that we can support and build on that. We have heard that is happening, but we're not too clear about the degree of adoption on that side of it. Next slide, please. So, just to reiterate the same points again, so LPC-CHL will liaise with general practice teams to prepare them for go live. General practice buy-in is absolutely crucial for service success, and we've spent a lot of time trying to get that buy-in and addressing their concerns and any barriers that they've come up with. And of course, we have had the same challenges that some of you have raised in the chat, and we are doing our best to mitigate that. General practice teams will receive support on providing the service, which will cover the GPIT systems, the conditions, the escalation process, the actual conditions that they can refer. So all that will be made very clear to them. We will keep you informed on the go live status, and we will ensure that you are communicated through the NHS shared mailbox. So please do continue to check your NHS shared mailbox. That's really, really critical, but we will try and use our WhatsApp groups as well, because that seems to be quite a good way to engage with you all. When a practice has a confirmed go live date, we will provide support around comms and engagement that needs to take place between the contractor and the practice to help you along that journey. Next slide. So this is a really important element of this process, is how you can help us. So it's really important that you brief your team and ensure that everybody knows how the service operates. I cannot emphasize how important this is, and I would, very much appreciate it if you could start this work now, and that includes your relief staff, your locum pharmacists, everybody in your team, because the confidence of general practice in community pharmacy is critical. If we get this right, we will get an increase in referrals. If we miss referrals, then it could be really, really challenging for us to get that momentum again. You can provide a simple overview of how the service works. That's Annex A in the toolkit. Please allow time for staff to familiarise themselves with the service specification and toolkit. So it's really important that you go back and provide that information to them. Obviously, Alison has already spoken about the virtual outcomes module, which again will be a great source of support. It's a really easy way to understand the service, and that could be a really useful tool for your teams. Discuss as a team how you can work together to make it a success. Ensure that all team members and locums understand daily activities required, and make sure that everybody is checking for referrals, and ensure that you all know how to identify a potential CPCS referral if they do not explain that when presenting. So Lou alluded to this earlier. It's really important that you try to make sure that somebody who's coming in, you check to see if it is a CPCS referral from the outset, because they may not say that it's a referral through that service. Okay, so at this point, I'm going to hand over back to Alison to chair the Q&A session. Thank you very much.
Thanks, Lovejoy, and thanks to Louise. That was really, really helpful and really informative. Thank you very much for sharing all that information with us. We do have a couple of questions that I thought it would be worth just talking about, so that everybody can get a full and comprehensive answer. So, Lovejoy, I'm going to pose the first question to you, if that's okay, please. We've had a couple of people asking about how a practice will choose which pharmacy a patient's going to be referred to. I think people are worried that there's going to be a negative impact on nomination. Potentially patients are going to get poached, for want of a better word, or some concerns about practices just picking the first pharmacy on the list, or the pharmacy that's closest to where the patient lives. So I was just wondering if you could maybe talk through for the guys on the webinar, what the process is going to be around how the practice chooses which pharmacy the patient will be referred to, sorry.
I think the first point to note that I want to make is we've done some extensive work with the GM Health and Social Care Partnership on prescription direction just in the last 3 weeks, because it's been a problem, not just for pharmacies in GM, but also for general practice. We will ensure that the training that we provide to the frontline staff in general practice will encourage patients to, referrals to be made to the nominated pharmacy that they already have. So it should be around patient choice, and it should be the regular pharmacy wherever possible. There may be some odd exceptions to that rule, but that is the stance we're going to take. And that is one of the reasons why we've done such extensive work. You may have seen a communication that's come out in the last couple of days about a very firm letter from the partnership about respecting patient choice and ensuring that prescription direction does not occur. So rest assured that we will be keeping that as a very core focus as part of the training and engagement we do. And I think that, there's a vested interest in this being successful for general practice and for community pharmacy. And if there are problems, we will troubleshoot and deal with them, because for the first at least 4 to 8 weeks, we'll be tracking and monitoring and following up with the practice and seeing how the project is going. So you will have our full support every step of the way to address any issues that occur.
Yeah, I suppose the engagement with the clinical director, although it's an important part of what we need to do, we can work around that. I think the clinical director engagement, we've got some brilliant engagement out there, and we've got, like I said before, we've got some that's not so great. Certainly as LPCs, we're linking in with the PCN leads, and we're going to support as much as we can to try and build those relationships with those clinical directors. But we don't envisage really that having much of an impact on how GPCS rolls out, because that's going to be a practice decision. So although whole PCNs may go live, it's not going to be dependent on any decision made by a clinical director. We hope it will be individual practices having those conversations with us, and that's how we're going to roll the service out, I suppose. So yeah, if you've got problems with your clinical directors and you've not got any engagement, please do get in touch and we'll support you as best we can. But rest assured, we don't anticipate it's going to cause huge problems for us with the rollout of the CPCS.
Fab, thanks Lou. Hopefully that's answered your questions. Lovejet, I'm just going to come back to you with a couple more questions if I can. Before I do that, we still do have another 10 minutes or so. So if there are any more questions that you want to ask either Louise or Lovejet or myself, please do pop them into the Q&A box. We've still got a little bit of time left to address anything else that you may have. And also please do remember to fill in that poll for us. Your feedback's really important. Okay, so Lovejet, a couple of questions for you then, please. There's something around looking at the data and looking at usage of the service, so identifying how much GPs are using the service, and is there any support once they're live to identify those practices that might not be making referrals or making as many referrals as we would have anticipated. And then another question really around what's stopping the practice from just telling people to go to the pharmacy rather than making a formal referral. We have had a couple of questions come through about that. So if you're okay just to cover those two questions, that'd be really helpful, please, Lovejet. Thank you.
Yeah, and just a quick point about just building on what Lou said, just to give you some assurance, we have actually presented as a CPCS working group to all clinical directors on a couple of occasions. So just to give you a bit of assurance that we have done some GM system engagement on that, and it's actually been clinical directors that have come back to us and said we're interested. So I think that's really positive, and I believe that once 1 or 2 or 3 or 4 clinical directors on board, then that should encourage others that are less willing or reluctant to do so in the future. So in terms of the data question, the NHS regional team are sharing the data for GP-CPCS referrals with the GP-CPCS working group. So when basically we have a go live date, we will have visibility of that data, and we will know how it's going. So it will not be a case of we go in, we train the practice staff, do a test referral and just disappear into the sunset. We will be working shoulder to shoulder with the practice and the pharmacies for a period of time until we can see that the referrals have started. So we anticipate that will go on at least at minimum weekly for the first at least month or so. If more support is needed, then we will continue. I'm here, Imogen's here, Ricky's here, Esther will be supporting, Lou will be supporting Alison, and we've got wider GM system engagement from directors of primary care who are very, very keen for this to work. So we will be monitoring this, and we will look to speak and engage with you as contractors as well to understand how you're feeling and how it's working. And so in tandem, that should really help us to improve the rate, the number of referrals, and maximize hopefully the opportunity to access that 6% that Lou referred to earlier. If I could just ask you to repeat the second question, yeah, I'd be very grateful, sorry.
Of course, no problem. It was around what is there to stop a surgery from just telling a patient to go to the pharmacy or to ring the pharmacy rather than making a referral? Because obviously in that case, we know from the service specification that the pharmacy can't make a claim for that consultation unless the electronic referral has been received from the practice. So I guess we need to provide some reassurance to the contractors on the call that won't happen, or it will certainly be minimised as much as possible.
Well, I'm going to be very frank with our contractors here. I certainly have been challenged by general practice and CDs on this matter, and quite abruptly saying, why do we even have to do an electronic referral? But we have done some extensive engagement with support from the Greater Manchester Health and Social Care Partnership on the fact that this is part of our community pharmacy contractual framework. There are national directions. It is, there's a service specification, there's a toolkit, and that has been approved and signed off by NHS E&I, and therefore that is the mechanism. And the answer I've said is, well, I can only use what the national referral mechanism is. And what we're trying to do is address the problems and barriers that they've identified, where they said, we do not want excessive administrative burden, but if this can be made easier for us through an integrated module or integrated IT, that will greatly reduce the pressure of us being able to make that referral. So I think in that sense, the fact that we've explained that process and we're trying to access that module, it really is a case of clicking one button and putting one line in to say, we are referring to you for a sore throat, and press that button and it will be over to referral. Now, the NHS Mail to NHS Mail option would have been a lot more challenging, and that's why in GM as a working group, we've decided that that's the route we want to go down, is to use either Farm Refer or the Patient Access EMIS module to reduce that administrative burden on both sides of the fence, actually, but also then to encourage that engagement with the service and not bypassing it. So I think it will be quite difficult for them to actually just refer the patient without using the pathway, to be honest. I mean, that's happening anyway, if I'm going to be honest, and we know that it's happening, which is why PSNC have asked all contractors to complete the audit, which you also kindly supported. And I can rest assured that these issues are also being discussed nationally as well, at the plot team with chief officers and also at the PSNC board. But from what we can see through our engagement, the practices that are early adopter sites are very keen to adopt the EMIS patient access module. So we don't anticipate that that's going to be a problem in GM. But if there is, like I said, we will be working shoulder to shoulder with the practice and working alongside community pharmacy. So if we see that kind of any such dynamics, then we will be in a position to be able to intervene and get support from our NHS local commissioners as well to mitigate that where we can.
Brill, thanks, Lovejoy. Really comprehensive answer there, thank you. I think another key point around trying to bypass the system is that if they make the referral electronically, the practice also gets that feedback from the pharmacy as to the outcome of the consultation, which obviously they wouldn't get if they just told the patient to go to the pharmacy. It's just another selling point, isn't there, for them to follow the correct process.
And the final one, Alison, sorry, is that the fact that actually gives an audit trail. So from a quality improvement perspective, they want the proof that, this service is going to work and this service delivers the outcomes that we say it's going to deliver. So we've been very, very straight and said that if you want that evidence and you really want to monitor it, we are only going to be able to prove the case and understand if it's worked if you actually make that referral. And I said that is absolutely critical to quality improvement and really measuring whether this service is genuinely reducing pressure from general practice. And so that's a real incentive really for the system to want to use the electronic referral system as well.
Brilliant, thank you. Just a couple more questions, conscious of time, because we're just 5 minutes before 8 o'clock. I've had a couple of questions, Lou, that I thought you could maybe respond to, which is around that local escalation process. If the pharmacist feels that a patient needs to be referred back to the general practice, how should the pharmacy make contact with that? There's some questions about whether they're going to be getting professional phone numbers. There's some issues with pharmacies not being able to get through to the surgery, and some of them almost giving up and having to use email instead. So I don't know if you could respond to that question quite quickly, if possible, please.
Yeah, I can do. So what we know from the pilots, and from the areas that are live now, is that about 10% of patients need escalation back to GP practice. So about 1 in 10 patients that you see will need an escalation back. And that'll be for conditions that a community pharmacy can't deal with for whatever reason. It could be that you feel that the patient's going to need an antibiotic, although we would never tell a patient they're going to get an antibiotic. But that could be, your gut feeling, that it's something that you can't treat. So we'll be referring those patients back for those reasons. What we'd advise you to do, and what we'll try and do as well as GP practices go live, is we'll try and collect any details of any private phone numbers that the practices have, professional lines, so that we can share those with you. You can also, as part of any discussions with the practice as you go live, ask for those numbers and just see if they're available. We know that some practices have them, we also know that some don't. I think really as part of the go live process, as we're discussing with and training the practices, we'll be having conversations with them just to ensure that they understand how pharmacies will do this, and that there will sometimes be a need for a practice to make an appointment available that day, you know, possibly by the duty doctor, and that pharmacists will be contacting them, and that'll be because it's the right thing to do, because it's part of the service and it's what needs to be done. So I suppose in reality, we understand that it can be difficult sometimes. Hopefully, if we get the training right at the GP practice, the number of people we need to refer back will be very small, and we'll support you as much as we can to get any of the contact details that we can. But we can't make any guarantees, I'm afraid, on that.
Thanks, Lou. Hopefully that's answered the question. I think so much of this service relies on those local relationships that you have with the practices that you work closely with. So whilst as a team we're supporting this implementation, there's some bits that you guys can do far better than we can, because you already have those relationships on the ground. I've had another couple of quick questions. One question, really quick response if we can. Lou, one to you. Can distance selling pharmacies provide this service?
Yes, they can. It's a nationally commissioned advanced service, so distance selling pharmacies can provide the service.
Fantastic, thank you. And what's the plans with further engagement for clinical directors of PCNs? Lovejoy, would you be able to just expand on that a little bit more, please?
Yeah, so what's happening is at the moment is that we've gone to wider forums where basically people are meeting in, you know, like there was probably 100 clinical directors, and not 100 clinical directors, but general practice colleagues that meet every Tuesday on a call that we went to present to, and we attend that regularly to continue that engagement. And we've also had some very, very good support from Janet and Tracy Bell, who are the GP provider board leads, to help engage this message. So the process is going to be this, that we've presented, we've left our contact details, and proactively, I must say, we've had a number of clinical directors and PCN colleagues that have got in touch proactively back with us to say that they're interested. So the first part of our phased rollout is to get 30% of practices live. So we are aiming to hit that target first. And I think that we are very close to have secured the number that we need to go to phase one. And that's actually been through clinical directors actually coming to us post our conversation saying we're interested to go ahead with this. So the first stage is to do an engagement piece to help them understand how the process is going to work, and the second phase is then to arrange the training, and the third phase will be when we agree that when the procurement happens for the EMIS, so that we can actually switch on the module, test it and go live. So this will be an ongoing process, and we will continue to keep engaging across the system. We have also started to engage at the CCG level. We are also going to be attending multiple practice managers forums. That's going to be coming up in the coming weeks as well, so that we will use every channel possible to try and engage with general practice. And also we will start contacting individual general practices as well, because we understand that not all the information filters down right down to practice level for reception staff. So we will exhaust all possibilities to make sure that we do that engagement. And it's a considerable amount of work, but we're getting through it.
Fantastic, thanks Lovejoy. Just conscious of time, quick question for Louise around locum agencies. Has there been any engagement with locum agencies about this service?
So not yet, Alison, no. I do think it's a really good point that's been raised there. So thank you for raising it. We are in the process of developing a locum guide that can be used for GP CPCS, so that we'll provide a copy of that hopefully to pharmacies, and that'll be pre-populated with some information, but also there'll be some gaps in there for you to fill in with your local detail. We'll probably provide copies of that to local agencies if we can do as well, because they'll be able to ensure that any locums that are being booked understand some of the wider processes within community pharmacy. So yeah, it's a really good question, and I think it's something that we can ensure gets done as part of our engagement and rollout.
Yeah, it's added to the to-do list, so thank you very much for that. Just going to wrap up now because we are a couple of minutes past 8 o'clock. If anybody's got any more burning questions that they really want to be answered, please do just stick them into the Q&A really quite quickly for us. Please do complete the poll if you haven't done so already, because your feedback's really important to us. And hopefully you found this session really interesting and useful. Hopefully you feel confident now in continuing or starting to provide the service to patients who are referred from general practice, and also to be able to claim your NXF setup fee. Don't forget the deadline for that is the 30th of June. So please do make sure that you get that claim in. Lou, I'm going to send this one through to you again because I think it may be a Bolton contractor, but it may not be. So it's a question around if the consultation results in advice to purchase a product over the counter, but the patient's not willing to spend the money. Is this grounds for referral back to the GP, considering we do not have a minor ailment scheme?
Right, we don't have a minor ailment scheme, and yes, I think this is a Bolton contractor who's put that on. And there's no plans by Bolton CCG, despite much lobbying over many years for us to have a minor ailment service. It's not looking that it's imminent, put it that way. However, we do continue the conversations with them. I think Bolton CCG have really been quite strict, and I'm sure that the pharmacists who's put the message on will notice that we get very few now prescriptions for OTC medicines. Even the standard paracetamol and stuff we saw years ago, I certainly see very little now on prescription. So I think patients who are unwilling to pay are going to be a problem. I think that in areas where there's been pilots where there hasn't been minor ailment service, because there has been pilots in those areas, it hasn't been as big a problem as pharmacists potentially thought it would be. A lot of the consultations end up in advice only, and there's not necessarily always a need for an OTC sale. I wouldn't be particularly encouraging you to send patients back for routine OTC medicines, because I think the message back from the practice will be quite clear that they don't prescribe them. That is my honest opinion. But it's probably something that we can pick up with practices and with the CCG as we start to go live as to how they'd like us to handle those particular questions, because it is very specific to us in Bolton, and we will feed that back to the Bolton contractors.
Thanks, Lou. And Lovejoy, just to confirm the status of minor ailments across the 9 GM localities, we had a question earlier around Oldham, so I don't know if you could maybe give a quick overview of GM minor ailment service in the other localities.
I'm going to have to pass on that one off the top of my head, because I know that there's actually 3 areas. Maybe I'll ask Esther, actually, she could kindly put it in the chat that we are nearly there, but there are still 2 areas from memory that are still in the process of going through the governance. The end launch date was supposed to be the 31st of March for all localities to go live, but that has not happened. So we are working closely with the partnership to make sure that we hope that everybody would go live at the same time, but unfortunately that has not happened because there's been extensive delays for the governance sign off through each CCG. So if that's okay, I'm going to take that offline. I can't remember at this precise moment. Sorry, my brain's blank.
Esther, have you got that info off the top of your head? Oh, she's just put it in the chat there. So it's Tameside and Glossop and Trafford are still working on local schemes. Oldham are not yet live with it, but everybody else is. So if you're in Trafford, Tameside and Glossop or Oldham, it's coming. And if you're anywhere else other than Bolton, you should have it already.
Thank you.
Fantastic. Thanks, Lovejoy. Thanks, Esther. Really helpful. So I'm going to draw the webinar to a close now. We are just slightly over time, so apologies for that. But I think we've had some really useful questions come through, and hopefully you found the Q&A session as useful as the content that we've shared.